and my pleasure to introduce Professor Walid bsata, who is an eminent hypertension expert and professor of cardiology and medicine at Aleppo University, as well as several other universities as an adjunct professor. He will enlighten us in this session about hypertension and cardiovascular and heart disease. Professor Walid, thank you very much.
Thank you very much, Prof. Walid, for the nice introduction. I mean, we'd like to thank you, all of you, for coming and participating in this meeting. I'll be talking about hypertension and the heart. And this is a very important problem because, as you know, I mean, many patients with hypertension, if they have a problem with hypertension uncontrolled, they will refer to cardiologists. And if you'll see also that most or all of the invited international speakers, they are cardiologists, and this will tell us that cardiologists, they are very interested in working in hypertension. And this is for the disclosure. I mean, we have to mention that there is no conflict of interest, but at the same time, I mean, we have to mention that we have many relationships with many of the pharmaceutical companies at different levels. This is the IMC hospital where I'm working. And this is a problem. If you will see the curse of hypertension, where many people, senior people in the world, they will end by having comorbidities, mortalities related to hypertension, MI, heart failure, atrial fibrillation, or whatever. So whatever you will do, your patient will end in a problem. But we need to protect our patient as early as possible. And this is one slide from the Framingham study. It will tell you that with changing age, increasing age, the level of problem with hypertension is different. It will start by diastolic hypertension and then systolic and diastolic. At older age, it will be mainly systolic hypertension. So this is very important to know how is our patient and what is the problem related to his hypertension. When we have increase of the blood pressure at very small level, I mean, only 20 millimeters systolic increase will have double the risk of cardiovascular mortality. So even minimal increase, it will tell us that our patient is going into a problem. So even at low level, our patient will go into a problem because of increased blood pressure. This is a slide from multiple studies and meta-analysis and showing a survey telling us that almost the majority of people, they have uncontrolled blood pressure. In Saudi Arabia, in Europe, almost 25 to 30% only they have controlled blood pressure. So the majority, they have uncontrolled blood pressure and they will end by having a problem related to that. And this is a result from the WHO, and this is very recent, almost 2 years ago. It will tell us that almost 33% of patients with hypertension, they have controlled blood pressure. This is all over the world, in 150 countries. So only a third of the people, they have hypertension, they have controlled, and because of that, they will end by having a problem. And this is the problem related to hypertension, the vascular problem, which is really related and because of high blood pressure. If you look at the mechanism, we have two mechanisms for the insult related to hypertension. One of them is endothelial damage, and you will have high blood pressure and you will have a problem related to the endothelial damage and causing endothelial dysfunction and a problem related to that. And the other one is hemodynamic, where you will have high blood pressure and high volume, and this will insult the arteries, and also at the same, not only the arteries, where you have the bifurcation, where you will be having stenosis more than the main artery. So we have two problems for the mechanism. The good news that if you will decrease blood pressure by 2 millimeter mercury, you will have good reduction of a problem. Good reduction is 7% reduction of ischemic heart disease and 10% reduction of stroke. So this is a good news. I mean, try to control blood pressure as much as you can, so control it before it will control you. I mean, this is the theme of our meeting for today. And this is William Osler. He mentioned very clearly, diagnose and diagnose and diagnose. Sometimes we have a problem. We will tell our patient, you don't have blood pressure. No, make sure that really he has or he doesn't have. When he has, try to treat him. So diagnosis is very important. And this is how your patient will be having a problem. Our patient is not the same. Not all our patients, they are identical. They might be having heart problem, coronary artery disease, heart failure, or valvular disease, or atrial fibrillation. So we have different types of patients with hypertension, and we need to adjust and to manage the patient accordingly. And the problem will start from hypertension, and sometimes we have comorbidities with that, obesity, diabetes, smoking, and all of these. And it will end by left ventricular hypertrophy, and you will have myocardial infarction sometimes, going into systolic and diastolic dysfunction, and ending by heart failure, which is advanced heart failure, and then death. So we have to manage our patients from the beginning if we can. How we'll define left ventricular hypertrophy? And this is very important. The definition, hypertension, it will be inducing abnormalities in cardiac structure. So many structures will be managed. I mean, left ventricular hypertrophy, abnormal left ventricular geometry, dilated left atrium, left ventricular systolic and diastolic dysfunction, and sometimes atrial fibrillation. So when we'll say left ventricular hypertrophy, most of the time we'll be having the majority of these, and at the same time this is hypertensive heart disease. What is the prevalence? The prevalence, it might be from 10% to 90%. Many patients, it means that they will have heart affected because of their hypertension. You have to manage and to assess and to evaluate the heart very clearly to make sure that your patient is really insulted and injured by his hypertension or not. And some of the problems related to hypertension that we call it doctor's inertia. Doctor's inertia, it means that some doctors, they feel that the blood pressure is okay. We don't need to manage. We don't need to lower it more than that. So our patient will ending by a problem related to high blood pressure, but not today, probably for a long time, which is not controlled very well. So this is an important slide, really. It will tell us about hypertension-mediated organ damage and how you will assess that one. Sometimes we have easy and simple and accurate way and cheap way to assess that one, like ECG, for example, like echocardiography sometimes, and sometimes we have difficult things like CT angio or like having calcium scoring, which is expensive and not available in all the hospitals. So we have to adjust and to manage our patients accordingly to whatever available in our hospital. When we'll say that the patient is having left ventricular hypertrophy, we'll look at ECG, but ECG, not most of the time it is abnormal. We'll look for voltage, for ST segment and T-wave changes. But if you look at the ECG itself, you'll find many abnormalities related to the hypertrophy. But if you want really a more clear and accurate and direct assessment of the hypertrophy, you have to go by echocardiography. And Dr. Hassan, he knows that echocardiography is more sensitive and more specific for hypertrophy than ECG. And always we say that if you look here, left ventricular hypertrophy, it will increase by increasing age. So it's not only because of hypertension. Whenever you are increasing in age, starting from 20 to 60 to 70, you will have left ventricular hypertrophy. And at the same time, if you have older age, you have left ventricular hypertrophy. If you have hypertension, you will be having, if it is more severe hypertension, you will be having more significant left ventricular hypertrophy. And this is abnormality really. Why? Because, I mean, look here, with increasing blood pressure in men or women, we'll have a problem of prevalence of the left ventricular hypertrophy. And whenever you are having hypertrophy, you have increasing mortality. So if you look at the left ventricular mass, with increasing mass, you will be having more mortality. So we have to adjust our patient to estimate and evaluate the left ventricular hypertrophy and the heart to make sure that we need really to control the blood pressure as much as we can. And this is very clear that progressive increase in cardiovascular morbidity, it is related, and mortality, it is related to left ventricular mass. Whenever you are having more mass index, mortality and morbidity will be higher. So don't forget it. I mean, when we'll say our patient is having LVH, we have to make sure really that this LVH is more related to mortality and morbidity, and we have to manage our patient accordingly. And this is a similar study showing that with increase of left ventricular mass, you will have less survival. So we have to reduce the left ventricular mass as much as we can. Is it related to coronary artery disease? No. This study is showing clearly if you have coronary artery disease or no coronary artery disease, only left ventricular hypertrophy is very much important, and it is showing a relationship to mortality in the patient. So in the absence even of coronary artery disease, it is important and we have to manage it accordingly. And this will tell us that try to make the diagnosis early, because when you will make the diagnosis, you will start managing and treating your patient. What happened? Okay. Most of the time we have to know that we don't have low-risk hypertension. I mean, the majority of patients with hypertension, they have slightly higher risk, and they have multiple risk factors. And this will tell us, these two studies showing that almost only 15% of the patients with hypertension, they have no risk. The majority, all of them, 85%, they have either one risk factor, 2 or 3 or more. So when you have more risk factor, it means that the problem is more and more. And this is an important point, the sympathetic overdrive or overactivity. And this will tell us that some patients, they have sympathetic overdrive, and some of them, they are hypertensive, young, diabetes mellitus, and this is a very common problem in our society and in all over the world right now. So we have to make sure that when we have sympathetic overactivity, it means that we have a problem. How we can manage that one? Beta blocker is the most important point where you will be able really to control and minimize the risk of sympathetic overactivity from the start to the end. From hypertension, myocardial infarction, sudden death, to heart failure, to everything. So all of these should be controlled or could be controlled by beta blocker. Norepinephrine and angiotensin II, these are the very most important problems in hypertension and in the mechanism. But at the same time, we have to check that our patient is having atrial fibrillation or no. Many reasons that our patient can go into atrial fibrillation. By age, it will increase, by hypertension, by diabetes, by obesity, and at the same time, by genetic factors. I mean, genetics, it plays a role in having a problem in the arrhythmia and in hypertension. And this will tell us then when you have a genotype problem, your phenotype will be different. So don't say because I'm young, I should not have. The genetics, it will play a role, and we have to assess our patient and to make sure the medical history, the family history, what is the relationship to that one. What is the atrial fibrillation? Is it a risk factor or a trigger? Probably it is both, because it will affect our heart and it will affect the mortality and morbidity of our patient. And it will have relationship to pressure and overload in the heart, increased atrial size, and at the same time, left ventricular hypertrophy, heart failure, systolic and diastolic, and tachycardia, and all the problems related to atrial fibrillation. And this study is showing clearly that if you have hypertensive patients, this is in the all-hat study, hypertensive patients, if they have atrial fibrillation or no atrial fibrillation, mortality, stroke, and MI will be higher if you have atrial fibrillation. So we should know the prognosis, and we should manage our patient according to the diagnosis. So diagnose the problem in order to make sure that you are not missing anything. When you have really atrial fibrillation and hypertension, the most important reasons to have atrial fibrillation is with increasing left ventricular mass. It means with hypertrophy and with increasing left atrial diameter. So when both are increased, you will have more and more prevalence of atrial fibrillation in our patients. So patients with hypertension should be managed very clearly to minimize that problem. What about coronary artery disease? Of course, hypertension is associated with coronary artery disease because we have the minimal coronary resistance will be higher with hypertension and coronary reserve will be lower. So our patients will be having coronary artery disease and problems related to that one. How we'll manage the patients? Do we have one optional way for changing and managing our patient? Do we have communist approach? The answer is no. I mean, we know that the American guidelines, they have put it very clearly in the guidelines that most of the figures, they are the same, but the European is slightly different. This is the European, only one slide about the European. In coronary artery disease, at younger age, the threshold for treatment, it is the same, more than 140. If you are older than 80 years old, the threshold will be slightly higher. So you need blood pressure higher than 140 to start the management for your patient. What about the American? The American is very easy in these guidelines. It is showing the goal is 130 in all of them, and it is showing that the threshold is 130 in all of them, apart from secondary stroke prevention, or if you have very high risk for atherosclerosis. The threshold to start treatment is 140. So remember always one figure, 130/80. We cannot remember all the figures from European and from all the others. When you choose your medication, you have to assess your patient and you have to assess the drug you will be using for your patient to make sure that really you are choosing the best one. In the last few slides of my presentation about stable heart ischemia, you will start by ACE inhibitor if you have hypertension, ARBs, and you have to go further for more medication if you have really uncontrolled blood pressure. Calcium channel blocker, dihydropyridine, this is very important in some of the patients. The last slide, it will show you that the first step combination, it is according how is the problem in our patient in specific condition. In diabetes, what we have to choose. In coronary artery disease, beta blocker or calcium channel blocker plus RAS blocker. This is very important. If you have heart failure, also it is important. Beta blockers is important in atrial fibrillation patients. So you have always problem with the pharmaceutical companies. They will give you a pen and they will tell you, please write our medication. Choose the medication according to the situation of your patient. And this is very important, really. Why it is important? Because we cannot have head-to-head study for everything. We cannot have study head-to-head. We have most of the time meta-analysis. And this is one of the meta-analysis in left ventricular hypertrophy. It is showing that probably ACE inhibitor is much better than the others, and another meta-analysis showing that ARBs is much better than even ACE inhibitor. So always we have to put in mind not only the guidelines, the practice and the experience and the meta-analysis. And I'd like to end my presentation showing that this is in the last meeting we have for Saudi Hypertension Society here in Jeddah, where we have some people even from Lebanon, Dr. Barbara, and many other people. And this is a photo for the board members of Saudi Hypertension Society. And this is the last slide is showing that we had a good relationship with the Turkish Society of Cardiology, and we had a meeting in Turkey before that, and we are very happy that the Turkish Society of Cardiology, Professor Mustafa and Professor Bitigen accepted our invitation, and thank you very much indeed.
Thank you. Thank you very much indeed. Excuse me. Thank you very much, Dr. Walid, for this excellent talk. And our next speaker, excuse my voice. Our next speaker is Professor Ferrari, Roberto Ferrari. He doesn't need an introduction, even with this voice. He's a world figure in the field of cardiology. He's the ex-president of the European Cardiac Society, and he is going to talk about hypertension, what is more important than in life. Thank you very much, Dr. Roberto.
Thank you, and a very good morning to all of you. It's a great pleasure for me to be back to Saudi Arabia, and particularly here to Jeddah. This morning I had the chance of jogging a little bit on the promenade, and it was really very, very nice. These are my disclosure, and I will start to saying that there is a very clear relationship between blood pressure or elevated blood pressure and outcome. And indeed, if we can control the blood pressure, we will be able to reduce the outcome. Unfortunately, I cannot point, and there is no... sorry? Here. Yeah, but it doesn't work.
No.
Yes, but the pointer.
Yeah.
The pointer doesn't work.
Doesn't
Okay.
show on this screen.
All right. And so you have to look the slides yourself without the help of a pointer. And as you know, rather recently in the United States, the guidelines have further reduced the target that we should reach for blood pressure to below 120 and 80. And this was mainly based on the results of the SPRINT trial and on a few meta-analyses. But all of you knows the problems that the SPRINT trial has created, particularly because the way how they did take the blood pressure, which is the appropriate way, but it is not what we are normally doing in our practice. The European guidelines also have reduced the target, but just below 130 and 80. And further, if this is achievable without too many effort. And this sentence is very important. In other words, you should not have to insist to reduce the blood pressure below 130, because what you are gaining in terms of outcome is very, very little. And therefore, if it is do. But if you have to put a lot of effort, forget about this. Now, you may ask why such drastic differences. And I believe that in US, it is just one country. They speak one language. They are very pragmatic. Do it. 2 studies are suggesting this. We don't really look whether these 2 studies has been done. Just do it and don't think about it. In Europe, and I should say at the EAC, by definition, we are a federation of more than 56 countries. speak in 37 different languages, and we need to adapt. We need to be political. We need to come to sometime more logical conclusion. And I didn't know what you are doing in Saudi Arabia, but I just had the opportunity to look at your guidelines because they were in my Congress bag, and I'm very pleased that you are following the ESC. That is very good. Now, there are, however, several considerations that we need to make. Because beside which guidelines you like to follow, the context is that the medical community, as you are not able, in the majority of the patients, even to reduce the blood pressure below 140. And we are always discussing in congresses how low we should go. But the reality is that patients are not really well treated. I give you an example. In Europe, 45% of patients with coronary artery disease who know that they are hypertensive, they remain hypertensive. 45%. This is an enormous amount of patients. And we are not really able to fully treat all the patients with hypertension. And that is true everywhere in the world. It is true in the US, particularly in the US. It is true in Asia, and I'm sure it is true also here in Saudi Arabia. And this, of course, is bad, because treatment of hypertension is very important. Now, which are the reasons for that? And what we are going to do about this? It is because the drugs do not work? No. We have several very effective drugs. It is because they are too expensive? No. In Europe, all the antihypertensive drugs are generic nowadays. It is because the patients do not take the pills? Yes. Probably this is one of the reasons. And another reason is that we, physicians, are not good enough to make the patients taking the pill. We are not good enough to convince the patients that taking the pills is very important. Sometimes probably we don't escalate or we don't counsel our patients enough. Sometimes we are worried about the guidelines, which are needless complicated. The important thing in front of a patient with high blood pressure is just to reduce it without thinking too much about the guidelines. And there are also other problems, because the pathophysiology of hypertension is very heterogeneous. And hypertension is a simple disease because I can measure it. But if I'm asking you to tell me the reason for hypertension and what is the pathophysiological problems of hypertension, is not an easy question, believe me. And why some people get high blood pressure is not an easy explanation. And also, blood pressure has multiple regulatory mechanisms, and not a single drug mechanism of action probably will be sufficient. And therefore, both the USA and the ESC guidelines are nowadays in agreement that combination therapy for hypertension is important. And perhaps we should start immediately with combination therapy, because sooner or later we will end with combination therapy. And of course, this has been shown that it is much more effective to add another drug than to increase the dose of the single drug. And so combination therapy is really very, very important. I have to go back. Can I? And I like to concentrate today on the possibility to reduce the renin-angiotensin system, and I will ask myself the question whether it is better to do that with an ACE inhibitor or with an ARB, because I believe that this is really an important question. Now, this system, it's a very important system which is there for millions of years, from the amyloids to the man. Its short activation is very useful for the maintenance of the species, and the system is there in order to avoid or to reduce bleeding. And this is because, as you know, angiotensin 2 is a very strong vasoconstrictor, and also it causes hypertrophy and repair. And by causing vasoconstrictions, of course, an excess of angiotensin 2 increases blood pressure. And this is a very good mechanism during hunting for the animals to avoid unnecessary bleeding. The problem is that overproduction of angiotensin 2 through the time causes vasoconstriction, hypertrophy, platelet aggregation. And we heard just a minute ago how important is hypertrophy for the prognosis of patients with high blood pressure. And in addition, there is a balance between angiotensin 2 and bradykinin. So if you have a prolonged activation of the renin-angiotensin system, you will have less bradykinin, which is important because is, and we will see why, is a very cardioprotective agent. So, not surprisingly, an overactivation of the renin-angiotensin system is found in many important diseases with which we have to deal every day. The first one being hypertension. And it is also important to remind you that this system is not only circulating, the ACE enzyme is not only in the blood, but it is also in the tissue, and it is also in the vessels. And that is the ACE that we need to target in a patient with hypertension. And now I would like to provide you my view, and although I said that I had been working with many drug companies, you have to understand that for 20 years I've been working with Perindopril and Perindopril arginine. So I might be biased in what I'm going to tell you, although I think I am not biased, and I will always provide you the evidence for what I'm going to tell you. Now, I don't have to come to Jeddah to tell you that Perindopril is a good antihypertensive agent, and also it is a very good and long-lasting antihypertensive agent. This is very known to all of you. What I am interested to is the fact that we do have several data, and these are just some of the data, but we have now more than 60,000 patients randomized to either placebo or Perindopril in many different clinical trials, and always producing extremely good results in terms of the best of the endpoint, which is all-cause mortality. You can see the results of Advance, Europa, and Progress, and it's quite interesting that Progress is the only randomized clinical trial in which an ACE inhibitor has been able to reduce also stroke in addition to myocardial infarction and so on. Now the question is whether all the ACE inhibitors are cardioprotective, and the answer is not. Here you can see 4 trials: the QUIET trial, in which we use quinapril, and unfortunately quinapril did not improve the outcome. Then there was the HOPE trial, and there we use ramipril, and the HOPE trial treated the patients at high risk for cardiovascular disease, and as you can see, the trial was stopped earlier because ramipril was better than placebo in reduce the outcome in terms of cardiovascular death, myocardial infarction, and stroke. And then we did Europa using Perindopril. I was the chairman of the Europa trial, and Europa enlarged the patients with coronary artery disease, not necessarily at high risk, but at no risk. And you can see that, again, Perindopril was very successful. And then there was the PEACE trial, which used Trandolapril and targeted almost exactly the same patients than in Europa. And unfortunately, there was no improvement in outcome. Oh, sorry. The question is why this difference? Because you see, one explanation is that ACE inhibitors may be cardioprotective because they are reducing blood pressure, and the blood pressure is a risk for myocardial infarction. But the problem is that Trandolapril and QUIET, they did reduce blood pressure even more than quinapril and ramipril. So must be something else to explain this good prognostic effect of ramipril and Perindopril. And, no, sorry. And so the question is, which is the mechanism? Is the protection of Perindopril specific? And do we have evidence that the ARB provide the same level of protection? And also, is there any other mechanism than just reduction of blood pressure? And I believe that the effect of the ACE inhibitors on the endothelium is very important. And the reason why I believe that is because when I'm saying cardioprotection, I mean reduction of myocardial infarction. And a myocardial infarction, to me, is not a disease of the heart, but is a disease of the endothelium of the coronary artery of the heart. Because if you have a normal endothelium, you will never have a thrombus formation in the coronary artery. And it is very important to remind you that the modern theory for atheroma formation and progression consider that there is a a struggle between the death and the regeneration of the endothelium. And this is very important. It's very important for you to realize that the endothelium of your coronary arteries commits a suicide, and it is regenerated almost every 3 months. It is a continuous cycle. I know that we are not used as a cardiologist to this, but I have to remind you that your red blood cells lives 120 days. I have to remind you that your neutrophils lives 7 hours. Have you thought about that? Every 7 hours, in this very moment, millions of neutrophils millions of cells are dying within our body, and they are regenerated. We do not feel it. We do not feel it because this is nature. The life and death cycle occurs in nature. You cannot have life without death. The leaves goes away in autumns and come back in the spring. We die and somebody is regenerated. And it is a cycle which is wanted by nature. And the death occurs because of apoptosis, and apoptosis is an extremely well-regulated process, starting from the nuclei, and there is a biochemical sequence which is destroying the cells in millions of apoptotic body without any reaction, and that is the reason why in this very moment millions of cells are dying within ourselves and we do not feel it. And there is a continuous regeneration. It is our society, in a way, which is considering life good and death bad. But for nature are two necessary processes. And when you have a lack of death, you have cancer. And so this is very important to remind. Now, every 3 months, the endothelium of your coronary arteries commits a suicide and it is regenerated. If this does not occur properly, you will have a hole in the floor of your coronary arteries. And if you have a hole in the floor of your flat, you will have a flooding behind. And that is exactly what is happening. If you have this mismatch, all the biochemical process of atherosclerosis will start and progress. And if you have a normal endothelium, that is the best possible protection against thrombus formation. Therefore, it is quite important to test the capacity of the endothelium to undergo to apoptosis and regeneration. And that is what we have done in a sub-study, the pertinent sub-study of the Europa trial. What we did, we isolated human endothelial coronary cells and went into non-endothelial cells around to see that coronary body of some position. In this particular experiment, in fact, these cells were considered coming from normal subjects or patients with coronary artery disease enrolled into the Europa trial. And by doing so, we could measure the apoptosis of the endothelium. Oh, sorry. And these are the very important results. As you can see here, in controls, the rate of apoptosis is about 3%. These are the patients with coronary artery disease involved in the Europa trial, before receiving placebo or before being treated for 1 year with Perindopril. And look, just because these patients had coronary artery disease, they are doing well. These are patients who had a previous bypass surgery, but they are doing very well. They are not necessarily hypertensive. They not necessarily have angina. They had a myocardial infarction 4 years before, or just a very successful PCI. But just because they had coronary artery disease, look, their endothelium is committing more suicide than normal. If you treat them with placebo for 1 year, if something, even higher apoptosis. But if you treat them with Perindopril, you have a reduction of the apoptosis. Not in every patient, but in the majority of them. And if you have an excess of apoptosis, you might expect to have some hole in the floor of the coronary artery, and therefore you have disruption of endothelial continuity, and that is the onset of atherosclerotic process. And if there is a plug which is already, covering, the endothelium is already covering a plug, it will be in that hole there and there that the thrombus formation will occur. And therefore, reducing apoptosis of the endothelium is very important. Now, the question is this a specific effect for Perindopril, or it is just a class effect? Very difficult question. And what we did, we explored this question in some animals. These are rats in which we increase the rate of apoptosis by liposaccharide infusion, and then we repeated the experiments with all these ACE inhibitors on board at a concentration able to reduce the blood pressure by 25%. I'm saying that because in the laboratory I can show you what I want by increasing the concentration. But I use similar concentration producing similar results on blood pressure. And you can see that enalapril does not reduce apoptosis, trandolapril does not reduce apoptosis, quinapril does not reduce apoptosis, ramipril does reduce apoptosis, and Perindopril does even better. Now, it's very difficult to jump from the laboratories to the clinic, but only ramipril and Perindopril in the clinic produce good outcome results. And this may be one of the reasons, at least. Next, sir. Okay. Now, how Perindopril reduce endothelial apoptosis? By which mechanism? Because it reduces angiotensin 2 and TNF-alpha, which are both pro-apoptotic agents, but mainly because it enhances bradykinin, which is a strong anti-apoptotic agent. And also, it is important to realize that not all the ACE inhibitors are the same, and what we want to target is the tissue ACE. And in order to do that, we have finished. And in order to do that, your ACE inhibitor needs to reach into the cell, and there are two classes of ACE inhibitors, those who are liposoluble and those who are hydrosoluble. And only the liposolubles have a higher affinity for the tissue ACE. I go quickly, and as you can see, Perindopril is the best ACE inhibitors to increase bradykinin. Now, what about, can you follow me with the slides? What about regeneration? You can see that Perindopril, when given to patients with angina, was able to increase the regeneration of the endothelial cells produced by the bone marrow. Therefore, I like to put to you that ACE inhibition is able to reduce the death and to improve the life of the endothelium. Now, what about the ARB? Because this is very important. Are ARB equivalent to ACE inhibitors? The answer is no. And we know that from many meta-analyses showing that the ARBs, if something, they can create even more infarct than reduce it. I go very quickly because I want to show you, can you just follow me, please? Okay. I just want to show you the reason why the ARBs are not protecting against myocardial infarction. Because, as you can see, angiotensin II is able to act on many different receptors, the so-called 81 and 82 receptors. 81 causes vasoconstriction, 82 vasodilatation, proliferation, anti-proliferation, anti-apoptosis, pro-apoptosis. The trick of nature, the yin and yang, the life and death, the opposite. And then nature try to regulate between the opposite. Now, when you are using an ARB, what you are doing, you are blocking the 81 receptor, so the all circulating angiotensin II now will bind to the 82 receptor, causing what? Vasodilatation. Very good. Very good. This is the antihypertensive effect of the ARB. But look, it causes also anti-proliferation and pro-apoptosis. And that is the reason why I believe the ARB might cause even more infarct instead of reducing it, because they do not have a good effect on the endothelium of the coronary arteries. Where are the data for that? Here we have been comparing Perindopril with Vasartan. You can see that with Perindopril there is a very clear reduction of apoptosis, no effect at all with Vasartan. And if you look at regeneration, you can see a very good effect with Perindopril, if something, even less regeneration with Vasartan. So, in conclusion, and sorry for speaking so long, the goal of hypertension treatment is to reduce blood pressure and the risk of cardiovascular mortality. This is very important. You have to reduce the risk of cardiovascular mortality. Both ACE inhibitors and ARB control blood pressure and prevent renal outcome. However, ACE inhibitors are far better than the ARBs in coronary artery disease prevention and reduction of overall mortality, even in patients with diabetes. And this is what worries me. If the medical community continues to ignore this evidence and continues to prescribe ARB for hypertension, the problem is that the patients will be deprived by the evidence-based medicine proven benefit of the ACE inhibitors. That is what is worrying me. Thank you very much for your attention.
Thank you very much, Roberto. I think it was a very excellent presentation and was also challenging. And there is a lot of sciences and a few of evidence that we need to look after. I think we're going to conclude the session with speaking about pharmacology, and it's my pleasure to introduce Dr. Ibrahim Hammasani. He's a clinical pharmacist, and now he's going to focus on the medical or medication in hypertension. So please share with welcoming Dr. Ibrahim.
Good morning. Assalamu alaikum, everybody. My talk will be just a quick summary and a very short talk. It's only 20 minutes. So we'll try to make this. Majority of the things is just a summary and repetition of what have been said this morning. So inshallah, we'll get going. So the important thing really, you have hypertensive patients. These patients need to be seen frequently until they really reach their target or close to their target. So every 1 to 2 months, the patient are relatively stable. However, patients with very high blood pressure, they need to be seen more frequently in the clinics. Once patients really approaches their target level, and you've heard a lot about targets this morning, slightly confusing. However, there are two magic numbers: 140 over less than 140 over 19, less than 130 over 80. Both of them are good. It depends on your patient population, depends on risk factor and cardiovascular risk factors. So once patient is stable and they're close to their target, then really you can see them, then you can see them every 3 to 6 months in the clinic. This is a quick intro. Why is this not? Okay. Now, why treat the blood pressure? Several randomized control studies and many meta-analyses really of those studies have shown that treatment of hypertension will decrease all major cardiovascular events by 20% and all-cause mortality by 10 to 15% and coronary events by 20% and heart failure by 40%. So you leave your patient alone, patient is treated but not controlled, then you end up with these major complications, or one of them. It's not working. Oh, turn back. Sorry. Okay. Now, really, treatment is very simple. Use any drug, any combination from those 5 groups or classes to treat hypertension. In the past, we used to say, well, use diuretics first, use this first, use that first, and so on. Evidence, and many evidences, randomized controlled studies, meta-analysis have shown these are the first-line 5 classes of medication. Then you can pick and choose. Obviously, there are certain situations where you have to fine-tune it and really zoom in on some specific agents. However, thiazide diuretics, ACE inhibitors, ARBs, and long-acting calcium channel blocker, dihydropyridine calcium channel blocker, and beta blockers at the bottom. So Dr. Abdul Hamid said 4, but I really agree, both the European and even the American now, they emphasize also the importance of beta blockers in patients who are less than 60 years of age, and we'll talk later why younger than 60. Usually combination of 2 to 3 first-line agents should be considered if systolic blood pressure is more than 20 millimeter of mercury above target or 10 of diastolic above target. The use of single pill combination where ACE and ARB is combined with calcium channel blocker or diuretic significantly enhances drug compliance and results in better achievement of blood pressure target. So monotherapy is more or less restricted to the perhaps high-risk patients with the high normal blood pressure like 130 to 139 or grade 1, 140 to 159. Perhaps you can try with monotherapy, just single agent, but majority of time you'll need at least 2 agents, if not 3. Hyperkalemia should be avoided all the time. Now let me try this again. Can we have the next slide, please? This doesn't seem to be always working. Now, randomized control studies, again, described trends. Now, why beta blockers? I put number 5 at the bottom of the 5 classes. Many studies have indicated that the beta blockers have got less favorable outcome on stroke prevention. And as you know, stroke is a major complication of hypertension. And also they have less favorable outcome on the regression of left ventricular hypertrophy. So this is why the role of beta blockers is in and out, but it depends on risk factor that your patient really is having. So beta blockers directly and partially, their combination as well, may predispose patient for increased risk of diabetes. And this is why we say less than 60, the risk is perhaps less, but as we age and so on, and insulin resistance and dietary habits, then the risk of diabetes becomes really higher in those patients. Combination of ACE and ARBs is really more or less contraindicated these days because of decrease on renal function and GFR. ACE and ARBs are potential teratogens, so avoid in pregnancy, and particularly in females with childbearing age. Hypertension in association with diabetes. I'll provide a summary at the end of this, and really I adopted this summary from the European Society of Hypertension and Cardiology, which is very simple. So really in diabetes, ACE and ARBs are really renoprotective, and they're excellent agents to use. Addition of calcium channel blocker is preferred over diuretics here. Reason diabetics really may interfere with the glucose control and may cause glucose intolerance. Addition of a loop diuretic is important if CKD is on board. Now, the hypertension association with cardiovascular diseases. In coronary artery disease, so ACE inhibitors or ARBs, beta blockers, long-acting calcium channel blockers are really the first-line agents. In stable angina, beta blockers or calcium channel may be used as initial treatment. When combination therapy is being used for high-risk hypertensive patients, ACE inhibitors with dihydropyridine is preferred, calcium channel blocker is preferred over combination with thiazide diuretics in coronary artery disease. Avoid short-acting nifedipine. Nobody should be using short-acting calcium channel blocker these days because of the risk of severe hypotension and perhaps coronary syndrome and ischemic attacks. So only long-acting calcium channel blockers are really recommended, and short-acting nifedipine has been really deleted from many hospital formularies. Combination of ACE and ARBs are contraindicated again, and be careful when really in coronary artery disease. Be careful when you're really lowering the blood pressure, not to lower it, not to lower it too much. You know, the diastolic blood pressure not to drop below 60, and then you create a problem with cardiac perfusion. Oops, we skipped one. Oops. Okay. So recent myocardial infarction. Here, the role of beta blockers is really very important. ACE inhibitors as well on top of that. ARBs only if ACE is intolerant. Long-acting calcium channel blocker, beta blocker contraindicated. Non-dihydrocalcium channel be used with concomitant. No non-dihydropyridine calcium channel like verapamil, diltiazem should not be used with heart failure. Now, if we have systolic dysfunction and heart failure, ACE inhibitors, again, always number one. Beta blockers, for sure, and perhaps smaller doses first, and you can titrate as tolerated. ARBs recommended if ACE inhibitors are not tolerated. Now, aldosterone antagonists or mineralocorticoid antagonists really became very important in the control of blood pressure in these patients, and this is about 6-7 years ago when those with having a heart failure class 2 to 4, New York Heart Association, sorry, 2 to 4. I'm trying to use the pointer, it doesn't work. So it really emphasizes the role of spironolactone, particularly in the treatment of heart failure. We continue second-line agents making it through sometimes. Hydralazine and isosorbide only if patients are not really controlled with the first-line agents, which is ACE inhibitors and calcium channel blockers. So hydralazine and isosorbide could be used only in heart failure. Dihydropyridine, calcium channel can also be used. ACE and ARB combination here only in heart failure could have been tried, There's still an option, but really the risk of having increased serum creatinine and perhaps decrease in GFR is very risky. Thiazide like that or loop diuretics are recommended as additive therapy in all heart failure conditions. Left ventricular hypertrophy, ACE inhibitors number 1, ARBs if not tolerated, long-acting calcium channel blockers or thiazide like diuretic. Direct arterial vasodilators, hydrogen monoxide here are not to be used and are contraindicated. Now post-stroke or TIA. Stroke is a big problem. What you need to do, you need to really lower the blood pressure very gradually and very slowly. And really a reduction of approximately 15 to 25% in the first 24 hours is very reasonable. But you also need to involve a neurologist here and a specialist because really it's very critical. You don't want to compromise circulation to the brain. Oops. So non-diabetic CKD, chronic kidney disease, ACE and ARB, of course. However, combination with diuretics and other agents may be used. Careful monitoring of renal function and potassium. One of the major problems with ACE and ARB, perhaps decrease in serum creatinine and decreased perfusion to the kidney. This may occur within the first 2 to 5 days, but up to 3 weeks of treatment. Now, as much as 30% increase in serum creatinine could be expected. More than 30% increase in serum creatinine is not accepted, and perhaps here a change in therapy will be really needed. However, from my experience and a lot of your big practitioners, majority of patients will have a slight increase in serum creatinine, like perhaps in the 5-10% ratio, and not more than that. In renal vascular disease, remember, if you have bilateral renal artery stenosis, then the use of ACE and ARBs is contraindicated because of the failure, because of risk of renal failure. So this is something, if you have unilateral, then it's not really a problem. Major complication. Now, I should really say here, if you've noticed in one of the first slides, I put diuretic on top of the list. Cost of the medication seems to be one of the major important factors in treatment and patient compliance for hypertension. In the Middle East, majority of patients do not have a free national health coverage. Big proportion of our patient population cannot afford the medications. They pay out of their own pockets. Now, guess what? Diuretics is still very cheap. The old generation ACE inhibitors are very cheap. Some calcium channel blockers are cheaper than others. Some older generation beta blockers are cheaper. Now, the message is use any medication to control blood pressure. So guess what? If a patient doesn't have any coverage and cannot afford to buy the expensive agent, then I believe you can really stick to any of the 5 classes that we mentioned initially, provided the patient can afford the treatment and he gets and really complies with your prescription. Otherwise, you cannot control the blood pressure. Now, another thing that you need to keep in mind, some of the major side effects of the antihypertensive agents. Thiazide diuretics are contraindicated in gout and hyperuricemia. They're also possibly contraindicated in the male gender, for example, if they are young male because of sexual dysfunction. They may become a metabolic syndrome. Glucose intolerance is something in pregnancy. They may cause hypercalcemia and hypokalemia. However, the compelling contraindication is really gout, and perhaps diabetes is another thing. This is not compelling but possible. The beta blockers in real asthmatic patients and COPDs or high-grade or sino-arterial or arteriovascular, if you have a heart block or bradycardias, then beta blockers are very problematic. But again, a lot of them may cause also male sexual dysfunction, or they cause a lot of sedation in patients receiving them, at least initially. They also cause glucose intolerance and hyperlipidemia, both for thiazide diuretics and beta blockers. Not all of them, but selected beta blockers may cause hyperlipidemia. Calcium channel blockers, usually the local edema or peripheral edema, lower limb edema, could be a problem. They may also really heart failure, class 3 to 4 is possible. and pre-existing leg edema. Tachyarrhythmia is another good reflex tachycardia. Calcium channel blockers, the non-dihydropyridine, verapamil and diltiazem, really they're not being very used these days for just the control of blood pressure unless you have to. ACE inhibitors contraindicated in pregnancy and the women of childbearing age if they're really still planning to get pregnant. This is something, but they are common in pregnancy. Previous angioneurotic edema, hyperkalemia, cough with ACE inhibitors is very common, and bilateral renal artery stenosis. ARBs, more or less the same thing, but they don't really cause any cough. So they could be an alternative in a lot of situations. Oops. Now, single pill combination has really, many studies have shown that the single pill combination is much more effective in controlling blood pressure because it helps really patients to comply with their treatment, with the treatment. You give one pill containing 2 or 3 medications for the whole day, and this is wonderful. The problem with this is the cost, and this is what I said. You want to treat the patient, or you want to give a patient a very costly medication that he will not buy. So really compliance here and patient financial situation should be taken. However, Europe, Canada, perhaps part of the UK, part of the US, this may not be a very big problem. In the Middle East, this remains a problem, patients affording the medications. And the list of all these medications and the combination, everything are available on Saudi FDA webpage, and you look under drug list, and you will really, drug search list, and you will really find the list and the cost as well. Am I running out of time? Yeah? Right. So I thought of a single pill combination. Other antihypertensive, all the other agents, they have specific indication. Centrally acting like clonidine is very famous. Patients not responding. We more or less use it mainly in hospitals. When we discharge patients, it causes severe postural hypotension and risk for fracture and fall. Alpha blockers, if you have patients with BPH, non-dihydropyridine calcium channel blockers, they have specific indications. The vasodilators, we talk about in heart failure, and mineralocorticoid like spironolactone is an excellent add-on medication these days to control uncontrolled blood pressure. The summary now, only allow me with this. I have 3 slides, and really I adopted this completely from the European, and really the European guidelines are excellent, very detailed, and very simple, and perhaps the clearest. Don't forget really the Saudi SHMS guidelines are excellent, to be honest. But these just came recently and did a bit of differences, really, and they're very well structured. If you really quickly look at this, ACE or ARB and calcium channel blocker, plus or minus, diuretic are there most of the times, and that's spironolactone. Very simple. Again, you have cardiac here. Same thing, ACE or ARB, beta blocker or calcium channel blocker, and you throw in a diuretic here. Oops. And finally, last slide. It's not going back. Thank you very much. Oh, it went back, but it's a bit too late. Thank you very much.
Thank you, Brother Ibrahim. I'm sorry for the time. May I invite all the speakers, please, to come to the podium? Roberto? Yes, Ibrahim, please. Walid and Dr. Ratel. Okay, so I'd like now to open the floor for the questions. Ibrahim, let me just start by you. Now, the guideline clearly indicating the importance of having a single pill combination. All the clinical pharmacists in different hospitals are very resistant to this concept. Yeah, single pill combination for hypertension management.
My hospital is also resistant to this.
Why is this, although the guideline is very clear?
I can tell you. We only have perhaps a couple of combinations. Hyazar, if you allow me, and Hyazar and the other, and Fortzar. This is the only combination we have. The problem is really inventory and the cost. Remember, hospitals, Can you hear? Near? I'll keep it near. Yeah, thank you. This one requires to be very close to the mouth. Okay. So really, majority of hospitals they really wonder about first maintaining the inventory and the cost of the inventory. But really, a lot of time, in the hospital, you have supervision from nursing staff and physician. In the community, you don't have this. So I have a patient admitted in the hospital. Now remember, many hospitals in the UK, not only in the UK, many hospitals in Canada and the US, you only treat patients while they are hospitalized. Then you write them a prescription to buy from the drugstore. Over here, the situation is slightly different. You see them, particularly in a big hospital and governmental hospital, you see them as inpatient, you also see them in the outpatient, and you give them inpatient medication, outpatient medication. In the West, this is not the case. You prescribe, you give them medication, they buy it themselves, or they have insurance coverage, then the insurance will pay. So hospitals here tend to spend much more on medications, and really add the single pill is really adding inventory and adding cost and increasing the drug budget. Where your drug budget will mainly be going to the difficult to treat conditions, equipment, and so on. Dr. Walid bsata wants to have state-of-the-art technology for his cardiac whatever, imaging. I want the oncology department wants to have state-of-the-art medications. Transplant patients are very demanding, and so on. So you cannot really afford to buy most of these single pill combinations. Particularly, you have somebody being treated under supervision in the hospital. This is really most of the time how people really look at it.
Thank you. I think the issue is really more than that, but I think the time doesn't allow us for this. Now, Roberto, the question to you, I mean, you show us a very good evidence about the difference between AC and R, but all the guidelines does not showing that difference. As a matter of fact, we always, in open any guidelines, always AC is the second phase for R.
This is this is a very important question. I'm afraid is a very political question, and I have to be careful in what I'm saying. The guidelines, if you read them properly and carefully, if you read the text, they clearly say that ACE inhibitors are more cardioprotective and there are more data than the ARB. However, we are reading the guidelines very quickly, always looking at few sentences, and the sentences says ACE inhibitors or ARB if ACE inhibitors are not tolerated. And it is in this if they are not tolerated that there is a lot of confusion, because particularly for hypertension, all suddenly the ACE inhibitor produce 20 or 40% of CAF, which they do not produce the same CAF in patients with heart failure, for instance. So when I'm said it's a very political and I have to be careful is because even the guidelines, how to say, there are lobbies, and you try to understand me, and so there are pushing. Now that the ARBs are all become generics, you will see that CAF is less of a problem with the ACE inhibitor, and will be less lobbying. But that was the situation, at least in Europe. Because you shouldn't forget that the ARB were somehow created in order to overcome the ACE inhibitors because they were becoming generics. And they have been done with a good purpose, and of course, and in the hope that they could really represent an advantage. But in this particular field of cardioprotection, unfortunately, this advantage is not there. and it has been shown by many meta-analyses. And but you know, people sometimes are under the influence of marketing and so on, and that is what is happening. That is my personal opinion, at least.
I have, if you allow me, one question to Professor Peterson. Always when we hear about guidelines, we hear about target or goal in the guidelines. And it's very confusing to me. I'm working in hypertension, and this is very confusing to me. Hypertension and coronary artery, hypertension and heart failure, hypertension and stroke, and renal and diabetes and whatever. The goal is different even from one age to another age. What is your comment? Our problem is to control the blood pressure as much as we can. But how we can remember always, most of the time, the goal and the target for blood pressure goal from different patients, and sometimes we have one patient who has 3 problems at the same time. So tell me how we can manage for the goal. Thank you. Difficult question, I know.
It's very difficult question because, in my opinion, in my opinion, acceptable range tension blood pressure range is acceptable range 120 to 140 acceptable range, better than one target number. If they have hypertension but coronary artery disease and diabetic patient, very low systolic blood pressure and very low diastolic blood pressure increase the mortality.
Next to your mouth,
Therefore,
microphone.
The target range.
Yes, thank you.
We have to focus the target systolic and diastolic blood pressure acceptable range 120 to 440 systolic and diastolic only 80 millimeter mercury. Strict range. Over the very low hypertension may be dangerous for increasing mortality, increased hospitalization, heart failure. Therefore, acceptable range is better than one target number, in my opinion.
Okay, thank you very much. I think we have a lot of questions, but because of the time, we have to conclude the session. Thank you very much, and inshallah, see you in the next session. Assalamu alaikum.
Comment was, don't worry.
Don't worry.
Just
live. Just do the medication. Yes. Control the blood pressure. I agree.
Just one second for the speaker, please. Can you stay, Dr. Roberto? Just 1 second. The lunch and the prayer will be in the Dunya B. Thank you. I will just have a plaques and certificate for the speaker.
Thank you, sir.
hospitals, they have all the combinations who are selected. Yeah. We do have, yes. We do have ISR, Cortisol, but not too much. Even for TB, we don't have the combination. Very good. Restricting. You know how much we have 1 year, 6 months supply. Then two weeks later, they come to the clinic, they change the whole medication, they do, if the patient is failing, we do the medication. Not by 6 months, or by 1 month. You see what I'm saying? Even in the He's great. Where are we having like downstairs? Okay.
And then at 7 we have appreciation gathering here. Then we go to
But 4 o'clock, where we go? In Myanmar?
We didn't start till now. Let's go
Thank you.
1 2 1 2 خلاص طيب احطه في جيبي طيب والبوينتر سوري هذا how you turn it off
صغير هذا
وين اوكي
حركه حطيت في اللمبه الخضراء
Okay. In normally, alt 05 is okay. It's short cut. It's very comfortable. Yes. Please help me during my presentation. Okay. And the second one, the first one, the doctor from Saudi Arabia, and second one. You went for lunch? Yes. عليكم السلام.
لما نبدا الشاشه متشغله ولا شغاله بس هو هم ثبتوا على سويتش شوفوا دايما السويتش ما he want to try to connect the cable to the switch.
Okay. Okay.
That's why
Enough for me outside.
Okay. Hello, hello. 1, 2, 3. You have to just put your mouth near.
Okay, okay.
Because the voice is not clear.
I will arrange, no problem for me. Okay.